Good morning. Get going in just a moment. Maya, just an FYI, I'm going to be covering the service today with you.
Okay, great.
I have two cases in the lab, so I may or may not be able to make NICU rounds. I'll try my best. Howie said that if he's free, he may cover it for me. But basically, after my second case, which should be done relatively early in the day, I'll be available the whole day.
All right, sounds good.
Thank you. Okay, why don't we get going? So this is the heart rate trend from a Zio patch on a patient. And question I'm asking is, do you think that this patient has an implantable cardiac device? Yes or no? And if so, how would you know that? So why don't we ask Dr. Bezdakova if she has any thoughts on this?
Morning, Dr. Pass.
Mhm.
So looking at this monitor, the top of the screen or the whole screen, we can see it's over a span of 48 hours from, and then looking at the monitor, looks like on the 17th, the heart rate overnight is lower, and then during the day it goes up. On the 17th, the max heart rates to be maybe in like the 120 range. Um, don't know the age of this patient, but the 120 is within a normal range if person is exercising or getting their heart rates up for various reasons. And then on the 18th, looking at the monitor.
There's no more recording. That's it says end there.
Oh, and okay. So, um,
So can you tell if this patient has a device or not? Is there any clue on this heart rate trend?
I think so if you look at the overnight recordings,
Hmm.
it looks like it's just like the heart rate is just set at 50 overnight, or not set, but the patient's heart rate is continuously 50, and there's not that much variability.
Well,
Uh,
it's a little more than 50, but yes,
yeah, so you know,
you're
I
hitting on it.
think that they do have an implantable device,
Right.
like a pacemaker. The heart rate really is set, seems to the lower limit if they were to have a pacemaker, that would be 50. It doesn't really go below that.
Again, I would remind you that the bottom of this is 50 and this is above 50, right? So it's some rate above 50, close to 50, but that's exactly right, Christina. So the point I'm trying to make in this little slide is that when the patient is asleep, presumably, we see that the lower rate limit almost looks like a completely straight line. Um, this is not a physiologic looking tracing. Um, and when you're in the ICU, you often will see this, that the line almost looks like you could take a ruler even and go across it. So presumably, just as you said, this is the lower rate limit is probably either 55 or 60. I'd have to figure out what this is in this patient. And so during the day, presumably this is a dual chamber device, right? Because with activity, the heart rate is going up. Now, it could be a single chamber device. So what feature would have to be turned on in order for this heart rate to be varying as much as we see it, as you described, Christina? If this were a single chamber, like a VVI, pacemaker, how would we know that this, how would the patient get their heart rate up, right? Because again, when we program a pacemaker, we set the lower rate limit. In this case, let's say it's 55. How would a single chamber pacemaker in someone who has heart block go up to those rates?
Would it be by setting an upper rate limit?
Mm, not no. I mean, remember that we really only can set a lower rate. We can set a tracking rate. There's also one other feature on a pacemaker that could potentially cause it to pace at faster rates. Any thoughts on that? Okay, so the most pacemakers have the ability for rate responsiveness, meaning that when the device senses activity, um, such as movement, there's a piezo in a Medtronic device, there's a piezoelectric crystal that can detect motion and will slowly raise the heart rate with the activity of the patient. And so it's possible that this heart rate variability that we're seeing could be either that the underlying ventricular escape rate gets faster under the setting of enhanced adrenergic tone, but usually most people in complete heart block cannot get their heart rate up to, 130 beats per minute. So more likely this is either, if this were a single chamber device, this would be so-called rate responsiveness. Remember, VVIR, the fourth letter is special features or functions. And in this case, it would be rate responsiveness, meaning that it would try to mimic a sinus node in activity. Now, pacemakers are notoriously not great at that. Depends on the technology. Medtronic uses a piezoelectric crystal. Other companies can use temperature of the patient. Some use respiratory rate. There's various different ways that these devices can try to mimic sinus node function. The other thing that's interesting is that where the patient's pacemaker is located in their body can also affect how sensitive the rate responsive feature is. So, for example, as you know, many of our patients who have epicardial systems have the device in their abdomen. In my experience, that does not usually result in a tremendous amount of rate variability. If it's up in the patient's left shoulder, as is the typical transvenous location, patients usually do have a little bit more rate responsiveness. And I'll tell you an interesting story. I had a patient for many, many years, I still follow him, who had a device in his abdomen. It was actually a pacemaker defibrillator. He was in complete heart block, and he had been for the first 20 years of his life. His device was in his abdomen, and the rate responsive feature was on. When his device broke, or I should say, when it was time to upgrade him to a transvenous system in his cephalic vein, I reprogrammed his new pacemaker to be exactly the same program that it was in his abdomen, and yet he felt like his heart was racing constantly, and he particularly was bothered when he was driving. And and so basically, as soon as I turned off the rate responsiveness, the feeling of a racing heartbeat went away instantly. And so the point is that when it was up in his shoulder, I guess the movement of bumping around in a car was setting the piezoelectric crystal, and it was making his heart rate go up, and he did not like the feeling. In general, people get very used to the rate that their heart normally is. And so particularly in pacemaker patients, if you have rate responsiveness on, in my experience, and you change, there's actually a way to change the sensitivity of the rate responsive feature so that less action will increase the heart rate more aggressively. And the few times that I've made an adjustment in that, patients have universally hated it. People get used to having slower, more steady heart rates, even though you or I might think that it's maybe an inadequate heart rate. They prefer it. In this case, this patient actually has a dual chamber pacemaker, and so what we're seeing here is just sinus node is increasing with being awake and active, and the ventricular lead is pacing in concert to it. Now, when you have rate responsiveness, you can those you had mentioned, Christina, the idea of like an upper rate limit. You do actually tell the device how high will you allow it to go up. In other words, we set the lower rate limit in every pacemaker. In this case, we've agreed that it's either 55 or 60. But you can, when you're setting the rate responsiveness, typically you'll tell the device, okay, the lower rate is 55 or 60, but the upper rate will say is 90 or 110. I never really make it very high because patients who are used to having slowish heart rates do not like the sensation of a very fast heart rate. Now, studies have shown that in general, these are not particularly good at the factory settings. The rate responsiveness is very poor. Dr. Fisher, who was the head of adult EP when I was at Montefiore, did a very simple study where he took like 100 patients with pacemakers and he put them on a treadmill and looked at their heart rate responses and with single chamber devices, and they were lousy, basically. And yet it's very rare that a patient complains. So anyway, I just thought I would show this. When you see this in the ICU, also, it's a very good sign that a patient is being paced. Any questions on that? Look forward. Oops. Yeah, there we go. Sorry. All right. This patient has congenital heart disease. It's an infant. And I saw them in the office for a consultation. And this was a few years ago. And this is the patient's electrocardiogram. So what is this rhythm? And do we need to treat it or do anything about this? How would you evaluate or manage this? So I am going to punt this over to Dr. Is Mohammed on the line? I think I saw him and then he left. Oh, okay. So why don't we ask Dr. Capon? What do you think, Dr. Capon?
Good morning, Dr. Bass.
How are you?
I'm good, thank you. Looking at the EKG here.
So remember, this patient has congenital heart disease. I'm only mentioning it because there are some unusual features to the electrocardiogram separate from the rhythm.
Yeah, so when I go through the EKG, I'm looking at leads 1, 2, and I see P wave, QRS, T wave. But then when I look at V1, it almost looks like there might be like an atrial electrogram or a deflection that corresponds with the P wave.
Just FYI, this is a surface electrocardiogram that was obtained in the office.
Okay.
But I do agree with your impression of that P wave.
Yeah, particularly in V1, it almost looks like as if we got an atrial electrogram.
Almost bigger than the QRS, right?
Yeah.
Strange. But of course, we know that in a lot of forms of congenital heart disease, patients can have right atrial enlargement or biatrial enlargement. So, but it is a very strange looking P wave.
All right. So I don't think we're in sinus rhythm, just going off the bat. So looking at the first lead, I see PQRST, PQRST, PQRST. And then as we move forward, it almost looks like we have, it looks like a ventricular escape beat or something along those lines when we get to the fourth and fifth beats.
You're talking about this beat here.
And the one thereafter.
And this one here, right?
Yeah. So you don't see a P wave preceding that, and in addition, you see a different QRS morphology.
Mm-hmm.
And then kind of going forward again, we see that interesting looking P wave, and then a QRS again, T wave. And then again, a PQRST. Sorry, I'm just walking through and seeing if I notice anything particular.
So I'm going to correct you. I do think the patient starts in sinus rhythm.
Yeah, the first 3 or 4 beats are sinus, and then...
And there are a couple of beats in the middle that look...
Yeah.
Right? These look kind of conductive, don't you agree?
Yeah, and you kind of waffle between those beats and then the beats with what I would say are ventricular escape. But they're on the faster side too.
Well, I mean, I think that, like, for example, if we look from here onward, this is PQRS, 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 and then this is, I think, what you're calling a PVC, which, by the way, I agree with. PQRS, 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 and then another PVC. So this is, interestingly enough, this patient was referred to me for evaluation of a history of SVT. But in actuality, what we're seeing is sinus rhythm
Ventricular
with
quadrigeminy.
ventricular ectopy. Yeah. So I just thought it was an interesting tracing because, sometimes when you see a narrow QRS, you just naturally assume that it's a conducted beat or it's a junctional beat, right? But I think we would agree that the morphology of these QRSs is very different than the morphology of the conducted QRSs, or at least in some leads it is. Like in this lead, right? This is one of these PVCs. This
Hmm.
almost looks like this. But if we look in multiple leads, we see that it's really very different. Um, so these are PVCs actually. Let me see here. We got a little chat here. Oh, I'm sorry. So how would we so what would you do if you saw this, Ivana? You're asked actually to evaluate the kid for SVT, but you are seeing this.
Well, in terms of what I would do, I'd examine the patient. I would also just be a little bit interested in that morphology of that P wave, which is really kind of throwing me off. And the P waves overall look a little bit high in amplitude. So I would echocardiogram this patient and see if there's any congenital heart disease. And PVCs aren't as common as PACs in the neonatal period, and especially with that frequency and that regularity. So I would echo them and then place a ZO on them.
Right. Now, what are you looking for in the ZO, you think? So,
Um, just in terms of overall frequency of the PVCs, if there's any continuity with them, couplets, triplets, or any runs of accelerated ventricular rhythm or VT, then
yeah, I think that's exactly right. You'd want to get a sense of what the burden of the PVCs is because particularly this is a single ventricle patient. So in a single ventricle patient, well, really in any patient, right? We've talked about how PVCs can cause cardiomyopathy, dysfunction, dilation of the ventricle. So you would really want to know what the burden is. And I think we might be a little more inclined to treat this. We've talked about what are the two main reasons that we would treat PVCs, Ivana, in somebody. You're in the office, somebody has PVCs, you do a ZO and they have a certain percentage. What would be the two main reasons that we would usually use rationales for treating PVCs?
if there's any decrease in cardiac function.
Right. So a tachycardia type induced cardiomyopathy. And we talked in the past that, adults generally think that like 20% is sort of the line in the sand. And we don't feel quite as strongly about that. But yes, if we saw cardiomyopathy, we would be concerned. What would be the other reason that we would treat PVCs?
I mean, I don't think you could really tell with a child this age, but if someone was symptomatic,
Yeah, if somebody was symptomatic, that's exactly right. Got it perfect. So there are two main reasons. If somebody is either symptomatic from the PVCs or if you're noticing dilation or dysfunction, those would be two very strong indications to either ablate it or put them on medication. And actually, interestingly, there's an article just this month in Heart Rhythm from, trying to forget where I read it from. It was a good group basically showing that they thought that flecainide was more successful in suppressing PVCs than beta blockers. It's a very small number of patients, though, and certainly would have to be confirmed. And of course, we all are aware of many potential problems or complications of using flecainide. But anyways, yeah, so the only thing I would say is that if somebody had like single ventricle disease where we are especially concerned about ventricular function, we might have a lower threshold to treat this because of concerns that, I always think about single ventricles as if we are tricking the circulation and asking one ventricle, oftentimes a right ventricle, to do the work of essentially two ventricles. And so all of these patients are already at somewhat of a major disadvantage. And so the point I'm trying to make is, you know, if we saw a certain burden of PVCs, I might treat that actually. So I agree with you. I would do a ZO or a Barty or a Holter and try to figure out how much PVCs there are and then go from there. Also see if there's any reason why a patient has PVCs. Typically, we don't know why they have it. But I just thought this was an interesting tracing because the P waves are actually larger than the QRS. The classic example where you see this, by the way, which this patient does not have, is when people have Epstein's anomaly. It's not uncommon that the P wave is actually larger than the QRS, but that's not the disease of this patient. All right, we move forward. Okay. So this is an ambulatory ECG. This is, equivalent of a Zio or a Holter or a Bardy. And this is an infant who has a history of tachycardia. So my question to you is, what do we think the likely etiology or mechanism of this is? And then how might you treat this? This is a patient who I think is 3 years old. I'm going to show you also, this is the termination of that rhythm, just in case you were wondering. So I'll go back to this. So why don't we ask Dr. Obsikov what he thinks is going on?
Good morning.
Hello.
Looks like the patient's heart rate was regular around a rate of 150-ish,
Mm-hmm.
and then jumps to about 200.
Yeah, I mean, just guys, it's set. This
It's
the
even
monitor
set.
actually tells us exactly, but very good, quick math there, Vlad.
That is helpful.
So the
Looks like
top is the cycle length
yeah.
for the electrophysiologist in the room, and the bottom is the heart rate for the cardiologist in the room.
And then it looks like as quickly as it started, it ends as abruptly.
Right, that's this tracing right here. So
That
can
makes
we
me think
make
it's
anything? So it does. So would we say that this is
a
more likely reentrant or an
yes,
automatic arrhythmia?
a reentrant.
Right, because I'll just remind everybody that reentrant arrhythmias are typically very sudden onset and offset, whereas automatic arrhythmias usually have a little bit of a heating up and a cooling down. Not 100%, but these rules are generally true. Okay. What else?
And then it looks like it's narrow complex and the QRS does not change.
Although again, we just learned in the last tracing that one lead can be misleading, but yes, I agree. It certainly does look like the QRS looks like the conducted beats at the beginning of the tracing when we're not in tachycardia.
And then I think I can convince myself that I actually see P waves before each QRS complex that looks similar to the P waves, the native ones prior to the onset.
So you're saying like this here? Is that what you're?
Correct.
Okay, so you're saying that you see this P wave and you're describing this as being just before the QRS. Another way to describe it is that it's after the last QRS. Okay. So can we surmise anything from the R to P interval in this case?
Trying to see if it's a short or
So you asked if it's short. What is the definition in your mind of a short R to P interval?
I think it's like 16 milliseconds.
It's actually 70. 70 milliseconds is usually the line in the sand, although my former fellow and a colleague, Scott Seresnak, wrote a paper a couple of years ago showing that in small kids, you could even use 50 milliseconds, but most people would say 70.
But it looks longer than that.
Yes, it does. Quite a bit longer, wouldn't you say?
Yeah, I'm getting a little over 100, I think.
Well, no, I mean, if the QRS is starting here, right? This is the retrograde P wave all the way over here. So it's over 200 milliseconds, right? It's like 210, 220, wouldn't you say?
Yes, sorry.
It's a very long RP interval here. So what would be the differential diagnosis of something like this, you think?
Like AVNRT,
Okay, so is the RP interval typically long or short in AV and RT?
Long,
No,
but
it's actually
unless it's
short.
I'm thinking of atypical.
Right. So in atypical AV and RT, it can be long. In those cases, you have you go down the fast pathway and up the slow pathway, which is the opposite of typical AV and RT. The most common AV and RT, you go down the slow and up the fast. Um, in the AV node, but in atypical, it can be the opposite. So yeah, it could be atypical, but that is I would say the second most likely. What would be the first most likely?
Like a PJRT.
Right, it could be PJRT because it's a very, very long RP interval, over 200 milliseconds. It could also be just ORT, right, through a regular pathway that happens to conduct a little slower than average. It's hard to say. Um, it's hard to say. The other interesting thing on this tracing is you notice it's very clear where the P waves are, right? This is actually a Barty device, and the theoretical benefit of what the company always says is when they're trying to convince me to use it here at Sinai and everywhere is that they have much clearer P waves than on a Zio. That might be true, but I think it's clear in this case, this is a nice example of that, where we see a P wave QRS, P wave QRS, P wave QRS, but then we see like 4 beats that have the same morphology, but we don't actually see a P wave. So it's interesting that the patient sort of seems to be having some junctional rhythm, and then goes into tachycardia. So I don't know what to make of that. I think when we terminate, again, we have sinus rhythm, and then we have one sinus, we have a P wave before a QRS, although, then we have a sinus beat, and then again, we have some of these junctional beats here, and then a sinus beat. So I don't know how to square those two together, why the patient's having a fair amount of junctional rhythm as well as what appears to be a reentrant arrhythmia, but clearly is having both. So this is a pretty complicated arrhythmia mix for this patient. So again, long RP interval, when we say long, when you say a long RP, what people are usually referring to is something like PJRT, or the permanent form of junctional reciprocating tachycardia, which I'll remind everybody is a misnomer. It really is just, you should think of it as an accessory pathway that conducts retrograde, just like any other accessory pathway in tachycardia, but conducts slowly so that the R to P interval is quite lengthy, typically over 200 milliseconds. And because of that, it's actually easy to have tachycardia because, the reason we've talked about this previously, the reason that people who have accessory pathways, right, when you have an accessory pathway, most people with tachycardia do not have it all the time. In fact, the majority of the time they are in sinus rhythm and are not in tachycardia. And yet, every single time that you depolarize the ventricle through your AV node, the pathway will try to conduct retrograde. And the reason we don't have SVT is, of course, because the atrium is still depolarized from the sinus beat, because the conduction is so rapid up the pathway that by the time it comes up to the atrium is not has not repolarized enough so that it can conduct that atrial impulse. So the impulse essentially is seeing a dead end. However, if you have a very slowly conducting pathway, as is the case in a so-called PJRT, by the time the impulse comes back up the pathway, the atrium may no longer be refractory and will allow for reentry. So paradoxically, it is easier to have SVT when you have PJRT, but the PJRT SVTs in general are slower because one of the limbs of the tachycardia circuit is slower, the retrograde limb. I don't know if this is PJRT in this patient. This could also be, it could be a form of AVNRT, where the P wave, it could be atypical AVNRT, could even be typical where the P wave precedes the onset of the QRS. But the bottom line is, I think one would need an electrophysiology study to figure out which of those possible diagnoses that is. But I would certainly say that this is almost certainly a reentrant arrhythmia based on the sudden onset and offset that we're seeing here. Any questions on that?
Sorry, Dr. Path, I have a question.
Sure.
How old is this patient? And you mentioned going for an EP study, but how do you do that when, let's say, the kid's so young and you don't want to take them to the cath lab when they're so little?
Well, I mean, again, it's a good question, and this is really a style question. Um, when we were on rounds yesterday, we had a young patient in the hospital who was having SVT, and Molly made the observation that if I were to take that patient to the cath lab, it would be the youngest patient she'd ever seen me ablate, and the patient was 8. Um, and so she's implying that I'm a very conservative electrophysiologist, only ablating and studying very big people. Dr. Love, will ablate a lot smaller patients, and lots of people will ablate smaller patients and take them to the lab. The decision to take them to the lab is really based on multiple factors. How important do you think the arrhythmia is? How easy or hard is it to control? And then some of it is just style. About 10 or 15 years ago, Andy Blaufox at Northwell wrote a paper when he was still a fellow or a very young attending when he was still in South Carolina, in which they demonstrated that even at age 2, you could safely ablate patients with a similar efficacy and safety. And a lot of people, based on that paper, decided that they could ablate small children. And I would make a few observations. The first thing I would say is that the senior author on that paper is a guy named Phil Saul, who is recently retired. But Phil Saul is one of the people who invented ablation in children and is probably certainly top 5 greatest pediatric electrophysiologists of all time. And so the idea that like everybody else thinks that they could be as good as Phil Saul, I think is false. The second reason that I don't love ablating small children is simply because we don't know what this arrhythmia is, right? If this happens to be a pathway, so where are pathways located in PJRT? Mostly, they're located in the posterior septal region. The posterior septal region is an area where the wall of the heart muscle has been demonstrated to be very thin-walled in all human beings, but particularly in smaller children. And there are many reports of people burning in the posterior septum in kids and inadvertently injuring epicardial coronary arteries. So the question is, in my mind, do I want to take that risk? If I knew it was PJRT, I would be a little nervous about doing that in a 3-year-old where I know already the heart wall is smaller and thinner. So do I really want to take that risk when I know that there might be a medical therapy to control it? Now, others would say, well, you don't really know it's PJRT. It could be a left lateral pathway, in which case you could ablate far away from it. Absolutely true. Others would say, there's medicine's not a free ride. You put somebody on a medicine, there's a chance they could give the wrong dose, might not work. Depending on what kind of heart disease problem you have, it could be dangerous to have SVT more than the average patient. So there are certainly competing interests. And there's no right answer, honestly. Some people who do a lot of small children ablations will say they're easier because remember, the tip of the ablation catheter is 4 millimeters, but the pathway is smaller in a 3-year-old than it is in a 12-year-old. And so maybe you don't need to be quite as precise in a small child because the relative size of the ablation tool is larger than the pathway in that age group. And so maybe success rates actually could be higher. There's also evidence in animal studies showing that lesions in small children grow a lot. And there's concern that, there could be long-term consequences of early ablation. So there's a lot of competing interests. I would never say that someone who wants to do ablations or EP studies in smaller kids is wrong. I think it's perfectly reasonable. But my own personal bias is that because of all of these potential risks, most patients can be fairly well managed with medical therapy until they're a little older, in which case I do believe not necessarily that the risk of the procedure is lower, but I think the risk of walking out of the procedure with success is higher when you are bigger. We can use more powerful catheters like the irrigated catheter, which I would be a little more concerned of using in a small child. But again, there isn't any evidence one way or the other. So in regards to your question, Ivana, this is a long way of saying the decision is really personalized. You know, if I had a patient like this who I tried on one or two medicines and it failed and they were constantly coming back to the ER, of course I would ablate them. And I have probably done about 30 to 50 kids under the age of 3 in my entire career. But these were all patients who, for me, who had had failed medical therapy, or maybe they were congenital heart patients where SVT was much more dangerous in terms of hemodynamic embarrassment than it would be in a non-congenital patient. So my general rule is to be conservative in this group, but sometimes, you know, you have to get off the pot and just do the right thing and just get rid of the damn thing.
Thank you.
Thank you. Any other questions? All right, I think we'll stop with that. Thank you for joining, and hope everybody has a wonderful day. See you at Sign Out soon.
Thank you.
Bye-bye.
Thanks.